You're listening to Aging Uncensored. Welcome back to Alphabet Soup Part 2.
Come back to the rest of the communities, but so we use the term ADLs and IADLs on a daily basis, right? So talk me through ADLs. Let's just start with the basics.
So ADLs are the things that you need to do every day in order to maintain your own life.
Right.
Yes.
Function.
So bathing, dressing, grooming, eating, toileting, transferring, all of those things are considered your activities of daily living.
Right. And one thing to note, so we'll talk about grooming, we'll talk about ambulating, which is, walking and so forth. A lot of times the first experience with what we call ADLs, activities of daily living, is when a family member looks at their long-term care insurance policy. And the way that you can qualify for your long-term care insurance policy is that you need assistance with at least 2 of either the 5 or 6 activities of daily living. So let's kind of break those down, because there's also, when we talk about long-term care insurance, we're talking about the level of need or the level of support and help that you need with these activities of daily living.
Just say ADLs.
ADLs, so much easier. Okay, bathing.
Yes.
So what if I can actually bathe by myself, but I'm a little unsteady and I just might need some help getting in the bathtub, out of the bathtub, in the shower, out of the shower. Maybe there's a big lip or things like that. What would we call that type of assistance for bathing?
That would be minimum assistance.
Or standby assistance.
Yeah, standby assistance.
Yes. And then we go to, I actually need help bathing my back or washing my hair or something like that.
Hands-on assistance.
Right, exactly. So then we have dressing. And you talked about the lower extremity dressing, which is usually one of the harder things. What is another hard thing, though, is, especially for women,
The bra.
And for men. Or
buttons,
anybody,
lots of buttons.
Women with blouses.
And a lot of times people with rotator cuff issues, if they're having troubles getting their shirt on and off because they can't come up and lift to get their shirt on.
Right.
So they need hands-on assistance with that.
Exactly. And sometimes people living with dementia, they can put their clothes on, but they need cueing, and they also may need some help and support choosing the right things.
Yes.
Right. So that's bathing and dressing. In long-term care insurance policies, they break down toileting and continence. So toileting, that's going to be needing help, maybe
getting on and off the toilet,
right,
and making sure that you're clean when you're leaving the toilet.
Exactly. And then continence care.
You're sitting in your lazy boy and you just wet yourself.
Right. And so now I need help cleaning that up.
Yes.
Right. So there is kind of a 2 breakdown there. And then they do have the activity of daily living of transferring. What is that?
So that is an actual either cueing and or physical help getting up from either a bed or a chair and moving your body to a wheelchair, another chair, or getting to your walker.
Right, right. And then there's also the sitting back down.
Yes,
right,
safely without plopping.
Right, plopping and leaning.
Controlled descent.
That's right. That's right. And then there's eating. So I think this is an activity of daily living that families kind of get tripped up on because they think, well, mom can't prepare her meal. That is not the actual definition of needing help with eating. What is the actual needing help with eating?
Getting the food from your plate to your mouth.
Yes. Yes. Just the simple act.
Yes.
So typically that is really one of the last ones that we see someone qualifies, unless there is an issue with their hands and motor skills and things like that. So, and then of course we talked about grooming and ambulation. So those are the activities of daily living. And we may have a client that says, or a family that says, well, mom has dementia, but she's still driving. She's living at home by herself, and she bathes and dresses by herself. Does she qualify for long-term care insurance?
Not usually.
No. Now, then there's another step. And really, this is another layer of support, but this doesn't mean you're going to qualify for long-term care insurance, but it may mean that you need extra support, like moving into an independent living community or moving to an assisted living community. And it's what we call IADLs, which are
instrumental activities of daily living.
So give me some examples.
So that would be related to kind of more independent living, like you said. That would be preparing meals, managing your medicines, managing your money, shopping for groceries, making sure that your housework is done, things of that nature. And I even say, like, making sure that things get on your calendar.
Yes, maintaining your calendar and appointments.
Yes, and getting to those appointments.
Being able to grocery shop and run errands, do things that you need to do to maintain living by yourself.
Right. The things that we hope our kids are going to know how to do when they leave the house.
Yes, they need to have all their IADLs in check.
Yes.
Hopefully they've been able to do their ADLs for a long time.
Right, but their IADLs, that's our job.
That's right, exactly. And so that's where you'll see the two levels of support and where they really fall into the communities, the facilities that we talked about. And so there comes a time when someone just needs help with everything, right? I mean, they need continuous help. Maybe they cannot get out of a bed. Maybe they're able, with extra assistance and help, actually hands-on, maybe even with a Hoyer lift, be able to get from a bed to a wheelchair. And at that point, that is where, if you're going through the communities and not maintaining them at home, they will need something that we call a SNF, a skilled nursing facility. And, we talked in the last episode about short-term rehab and things like that. But when we're talking about SNF as it relates to this continuum of care, it is what we call like a long-term nursing home. So tell us about what that looks like.
So that is more of a medical model where the primary goal of the people that are working in that facility or community, they want to make sure that you are well fed, you're not dead, you've had your medicines, you get a regular visit from a doctor, all of those sorts of things. They will have CNAs. So these are people that have actually got a certification in maintaining ADLs for someone's care. You've got nurses around the clock. You've got a medical director that comes usually weekly.
Right.
And then you also have different systems in place to hopefully make sure that that person is functioning at their highest medical level possible. Then you throw in activities and having fun and things of that nature.
Sure. And we've seen a lot of changes over the past, 2 decades really, of what the models look like, right? So you have kind of a traditional model of skilled nursing, and then we've seen where a couple of communities have tried the more home-like setting. And when they start the home-like setting, it actually does really well, but I do think it's such a culture shift for a lot of traditional operators that it's hard to really maintain that level of kind of a home-like setting.
Yeah. You have a like you said, a culture shift where in a skilled nursing facility, generally the lowest people on the totem pole, so to speak, are the residents and the CNAs.
Right.
And then everyone else has a say of what goes on in those communities, what happens to the CNAs, what happens to the residents, how they live their lives, how they work their jobs. The idea of like a more green model or a home-like model is that the residents, the people that are living in the facilities, come first. They get to say what they want to do throughout the day, when they want to do it. The CNAs are the ones that are supposed to be their advocates, so they're second in that model.
I think sometimes they're called like homemakers.
Homemakers,
they'll use that term.
Yeah. So those are the people that are supposed to be there in support of. And so the idea behind that is that they're the ones who are generally the boss because they're advocating for the people that are trying to live their best lives. Right. So usually in a model like that, if there is enough supervision and oversight and you don't have people that have been, living, working I say living, working, because it feels like you're living in a facility sometimes. When you're working in a facility for 25 years, you kind of get into a mindset of this is what we do every day. And it's not that this person, Mr. Jones, wants his shower or his bath at Monday after breakfast. It's more of this room gets a bath Tuesday, Thursday, Saturday after dinner. Right. That's on my schedule.
Right. Not the person, not Mr. Jones, room 112.
Yes.
The even numbers get their showers at this date versus Mr. Jones and Mrs.
Exactly.
Smith.
Exactly.
Yeah.
So if you have a staff person that's open to that change and that's open to going with the flow and is more of a creative, outside of the box thinker, then those models work beautifully. Usually you have more plants in those communities. You have intergenerational activities. Some places will actually have daycares for the staff members there so that the people living there and kids can get together on a regular basis and learn from each other and nurture each other. Oftentimes you have pets, and it's a much more livable model.
I think probably one of the best skilled nursing facilities in our area that has been able to maintain that home-like approach and has all the multi-generational and the outside activities that just enrich these residents' lives is our VA nursing home in Pell City. So this is about 25, 30 minutes from where we are in Birmingham, and it's called the Colonel Robert L. Howard Home. And they really have done a beautiful job. They have 3 different homes, if you will, on each hall, whether it's Liberty Hall or Freedom Hall. I can't remember the third one. But they do such a great job of having just like 9 or 10 private rooms, and they're little courtyard, and they're off of a common space, which is a kitchen, a den area. They have dedicated staff that stay within that community, and their needs are met right there versus having to go down into a dining room or something like that. So, and I think that they've started that model and they've been able to maintain that model. We've seen where some communities have started it and did well for a while, and then maybe after the pandemic or things like that, it was hard to get back to that level.
And you really have to have buy-in, and you have to have administrators that believe in culture change and are not just, checking boxes and doing their monthly QA reports and things of that nature. For those who are interested, if you look up Bill Thomas and the greenhouse model, he and his wife have different books about how they came up with that model and why it's important and how they implemented it in facilities that he was a medical director at one time.
Absolutely. So it's always good to research these things. And when you're going through finding the right place for your loved one, it's important to consider what they're able to do, what needs they have, their personality. I had a grandmother that lived in the city. I had a grandmother that lived in the country. Where I would recommend my grandmother from the country to live in is different than where my grandmother from the city would live in. Right. It's very different. What are their needs? Do they have more Bible studies and, have the bigger meal at lunch and then the smaller meal at dinner? That would be my grandmother in the country. And then my grandmother in the city would want the bridge clubs and the martini hour and all those things. So what does that look like? And then to kind of wrap up the communities, we talk about, you'll hear the term CCRC, Continuous Care Retirement Community. And that is a community that has everything from independent living, assisted living, memory care, or what we said, specialty care assisted living, and of course, nursing homes. You have all levels, and it tries to be age in place, but really what it is that you're just aging through their continuum levels of care so that you can stay within that community.
You hope. Because each one has a different license, and they may be at full capacity, or they may say, oh, Lewy body, we don't accept that in our skilled nursing anymore.
Right.
So at that point, you're left thinking you're going to go through a community. You've done your buy-in, which paying hundreds of thousands of dollars. hoping that you're going to be there through the end of your life, when in reality, anything could happen and you're out looking for a new community.
Right. And that's really why we tell parents or tell families, don't get locked into what the if your loved one may need higher levels of care down the road. Let's find the community that they need right now.
Right.
Because if they do need a higher level of care in a couple of years, whether they're moving to the assisted living that's on campus or they're moving to an assisted living that's 20 miles down the way, it really does not matter. It's going to be a change. It's a different room. It's a different community, different staff, everything. That's right. And Taylor's over there reminding us of one of the things we didn't talk about, which we should talk about when we're looking at different levels of community, is how much it costs. Right? So if I'm on a limited budget, we may be looking kind of outside the urban areas, more in, kind of smaller communities and so forth, versus someone that, cost is not an issue and they want the 3-bedroom independent living apartment and
they can spend $10,000 to $15,000 a month on added services.
That's right. That's right. And that is a whole nother podcast on how we pay for things and what it looks like. But I'm glad she mentioned that, because that probably is number one when we're discussing where to go. So we've talked a lot about the levels of care as far as the communities. Now, there's so many different services that can come into the home. They can even come into assisted living, independent living, memory care. They can come into skilled nursing, all of these things. Some of them are paid through your insurance and some of them are paid private pay. So let's start with probably the most basic level, which is direct caregiving. You'll hear it called sitters,
homemakers,
caregivers,
care partners,
companions. You may have a CNA, like we mentioned, a certified nursing assistant that's now working for a home care agency.
My favorite one, the live-in help.
The live-in help, yes. Live-in help, absolutely. So how is that paid?
Privately.
Out of your pocket.
Out of your pocket. But if you have a long-term care insurance policy and you can prove that you need help with your activities of daily living, then they might pay for some of it.
If they have a home-based care portion of their insurance policy. Right.
Or if you're a veteran and you can prove that someone is caring for you, then there is a veteran's benefit that will pay for a family member to give you care.
Yeah, and so that's all. We can do 2 or 3 episodes on veterans benefits, and we will at some point. But that to be said, that's where you need an aging life care expert
who can lay it out for you
through all these things, and what does it look like, and what's the pay, and in more urban areas, it's going to be more expensive versus in smaller communities. In smaller communities, you don't have a lot of home care agencies. Because really everybody kind of connects around the faith-based communities, and that's where they're getting referrals and so forth. Whereas like in Birmingham where we live, there's I think over 100 agencies.
Oh, yeah. There's new pop-ups all the time.
All the time. And it's that is, we have a lot of good friends that own home care agencies, and it's a tough job being a caregiver, and it's a tough job owning a caregiving agency.
Yes, because once that person leaves your office, they're representing you and you have no idea what they're doing while they're on the clock.
Absolutely. And they're covering their workman's comp, they're covering their unemployment, they're covering so many different things that makes what they can actually pay the caregiver versus what they're charging the client. It's very small cushion. So that is what you'll hear called home care, private care, home care agency.
All of the things.
All of the things. That's right. So then let's dive into something that will be kind of on a short-term basis, and it's covered under your insurance, which is home health care. Not to be confused with home care, but home health care. Walk me through that.
So that is if you've had a change in condition or some sort of failure, fall, something that's happened.
Infection with antibiotics.
Hospital stay.
Right.
Your doctor, any of your doctors can put in an order for home health care. And once that order goes to that home health care, it could be a number of different ones. Again, there's hundreds of them. Medicare will pay for support to intermittently come into the home, whether it's a nurse, a physical therapist, an occupational therapist, a speech therapist, a bath aide, someone to get you over that hump, train you in the proper ways of moving about your home, or helping you to find solutions to things like a ramp or eating utensils that prevent you from shaking.
Safety devices, grab bars, things like that you might need to be. But they'll recommend it.
Yes, they have a certain number of visits that Medicare will cover, and then you have to go through a recertification. So if that therapist or that nurse can't prove that you're making progress and still benefiting from their visits, then those visits will be cut off.
Right. So who are the licensed providers that are coming into the home?
An RN, an occupational
nurse,
therapist,
RN, registered nurse,
an occupational therapist assistant.
So that's an OT and a CODA.
Yes. A physical therapist,
PT,
and a physical therapy assistant,
PTA,
and a bath aide.
A CNA,
and then a
usually. Speech therapist. That's right.
Yes. And so you will have a nurse come in and do the assessment, and then you'll have a different nurse come in and do your medicines and your care and your wound care and things of that nature. You'll have the physical therapist come in and do the assessment, but then the physical therapy assistant is the one who's actually coming in to do all of the exercises with you.
Yeah.
So.
And then the same with an OT, occupational therapist, and the CODA. That's going to be looking at how well you can do your activities of daily living.
Right.
Do you need help, with bathing? Are there devices like grabbers or things that you might need? What about safety in the bathtub and the shower and things like that?
And if you don't have a piece of equipment, a DME, a durable medical equipment, they will order those things and Medicare generally pays for them. You may have a copay for something like a wheelchair or
hospital bed, walker,
something else.
What have you.
Yeah. And usually you don't necessarily have hospital beds for home health. That's more of like hospice or things of that nature, but they'll make sure that you have what you need.
Yeah, absolutely. And so, you mentioned Medicare's covering this. That is something I also want to touch back on when we were talking about the skilled nursing facility, home health care, and then we're going to get into hospice. Because they all receive reimbursement from Medicare and Medicaid, they are now under the national umbrella of the Center for Medicare and Medicaid Services to meet those regulations. So not only do they meet the state regulations, they have to meet national regulations in a skilled nursing, home health care, and then we're going to transition to hospice. So we love hospice. We are big cheerleaders, proponents of hospice. We have walked through hospice care with many of our clients, and then personally, with our loved ones. I've walked through it with my uncle, my aunt, and my father, and could not have provided the level of care and support that they needed and the family needed if we hadn't had hospice. But hospice gets a bad rap. Talk to me about that.
The idea for hospice is that it's supportive services to make sure that a person has everything they need in order to comfortably die wherever they are. So that could be at home, that could be in assisted living, in a skilled nursing facility, in an independent living facility, in an in-house hospice
Does this mean they're going to die in like 2 days?
No. It means that they have a chronic health condition that will eventually cause their death.
And they're not, it's terminal. They're not going to improve, and it's not going to be cured.
Right.
So we may have someone, particularly when they meet the criteria for maybe like congestive heart failure, or they meet the criteria for some levels of dementia and so forth, they may maintain for years. And there are even times when maybe everybody's been doing such a great job for their care that when it's time for recertification, they actually don't meet criteria for hospice anymore. And they may roll off of service for some time.
Right. But oftentimes it's reported by, a lot of people that we work with in the industry that oftentimes family members won't utilize hospice until the very, very end. Like hospice comes in on a Monday and on Tuesday that person's gone because family members can't, in essence, they feel like they're letting go or they're giving up on, and they don't necessarily understand that hospice is there to relieve in some way the symptoms that person is having due to that condition.
Right, exactly. And then one thing that people don't understand or know is you talked about the co-pays with home health, like if you're getting a wheelchair or a hospital bed or something like that. When you are approved for hospice services, every piece of equipment that I can imagine is provided.
They'll even bring what you don't need.
They'll bring what you don't need. But incontinence products, nutritional products, they bring so many things and provide for that person, and resources for the family, like a chaplain and a social worker. All of these interdisciplinary staff members that are able to help that family and the person who has the terminal illness with their journey and what that looks like.
You don't receive, and this is one thing to maybe discuss, you don't receive active help. If you are on hospice for cancer, you're not receiving chemotherapy.
Right.
You are getting pain medicine, you're getting nutrition, you're getting, if you have an issue and have wounds, you're getting wound care. It's things that stem from that illness, but you're not actively treating that illness.
And the other nice thing is, let's say mom's been a revolving door for urinary tract infections or things like that have taken her in and out of the hospital, which requires emergency room. And you could be in an emergency room for 24 hours and then going in inpatient and all the things that happen to someone go with an infection and chronic illnesses in the hospital. Now, when you have an issue, you call the 24/7 hospice nurse and they come in, they assess, and they provide what is needed in the home.
Right. And you can come off of hospice at any time. If you fall and you have a gigantic laceration or a deep cut and you need someone to go to the emergency room right away, get it stitched up, you can come off of hospice for that amount of time that you're there and then come back home and get back onto hospice.
Right, right. And with the right nurse and hospice company that's going to guide you through this process, it really can be seamless.
Yeah.
And from the most part, every hospice nurse that I've encountered are angels. They are angels here, and they they do this because it's a calling.
Right.
They really do. I'm not going to say that you're not going to have, a bad apple here and there, but that's anywhere.
There's
in any
jerks
service.
everywhere.
There's jerks everywhere. But for the most part, they really are angels on earth. And they are here to help and guide everybody through the journey. That what's the name of the blue book that they always give us?
Gone From My Sight.
Gone From My Sight, which is really a cool, very simple, I think it's written in like a 6th or 7th grade level of what does it look like as my loved one's going through the dying process, and teaching and educating them through the process.
And it really talks about things like withdrawing from society, withdrawing from friends, withdrawing from family, withdrawing from spouses, and kind of each stage of what that looks like, about how long each stage takes, and what the active dying process looks like for most people.
Right, exactly. Now, one thing that I kind of skipped from home health to hospice, and this is relatively new. It hadn't been around for a very long time, but this is also covered under Medicare, insurance, things like that, is palliative care. And you'll see the home health companies or the hospice companies or both offer a level of service called palliative care, which is what we think is hospice, right? So when would somebody qualify for palliative care?
When they have a chronic condition that is affecting their day-to-day lives and they need extra supportive services that the hospital, the doctor, the specialist can't provide, palliative care comes in with things like a chaplain, a social worker, different nurse practitioner, nutritionist, people that come in and give you a different level of support so that you can live comfortably with that condition and still be treated for that condition. So if it's something
treated and still getting home health, like physical therapy and occupational therapy and things like that. Yeah.
So if you have cancer or heart condition, you can still be actively treating that condition and receive palliative services. And our local UAB has inpatient and outpatient. And then, like you said, we have several home health and hospice communities that have that different.
Right.
But you still have to qualify for it. And it's a lot separate, in my opinion, it's separate license. So you have a different medical director, different staff, things of that nature that come out. So if you're on palliative care with a company and then you switch to hospice care with that same company, you're going to get a different staff that comes out.
Right. Exactly.
Check out part 3 for a continued conversation about alphabet soup.